All right, it's 12 o'clock, so I think we can get started. Good morning or afternoon, everyone, depending on what time zone you're in. My name is Rich Maiman. I'm one of the chief residents at Montefiore Medical Center in New York. Today is my great pleasure to introduce Dr. Kara Watts. Dr. Watts did her residency training here at Montefiore and stayed on as faculty afterwards. Today, she's going to be talking to us about prostate MRI for the urologist. And I'll turn it over to her now. And if anyone has any questions, you can just ask them in the chat, and we'll try to get to as many as possible after the talk.
All right. So thanks, Rich, and thanks to everyone for, I guess, tuning in today. This is my first time doing this type of a Grand Rounds lecture, so appreciate everyone's going along with this and the opportunity to speak with you. I don't have any disclosures. So as Rich mentioned, we are at Montefiore Medical Center, which is located in the Bronx, New York. And for those of you who may not be as familiar with our program, I wanted to just briefly mention a couple things about it. So we own Albert Einstein College of Medicine, and we are actually one of the largest hospital healthcare networks in the country. Our hospital network comprises 8 hospitals, 3 of which are our primary academic hospitals. This fancy, shiny building on the upper right-hand corner is one of our newer outpatient centers where our outpatient urology practices, as well as our ambulatory surgery center. And we service the community that live in the Bronx, and it's 1.4 million people. It's a ton of patients with an unbelievable amount of diversity. Montefiore has one of the largest residency programs in the country across all specialties, and also we have one of the 5 busiest emergency rooms in the country. And so it's an amazing place to train, an amazing place to work at. And one small fact I love to always mention is that our faculty just so happens to be almost 50% female, which is very unique among urology practices and academic centers. Okay, so a brief outline for today. I'm going to start with some basic prostate anatomy on MRI, go over the PI-RADS scoring system for prostate cancer. I know there were previous talks on fusion biopsy, which is something, I'm one of the 2 faculty in our department who do image-guided fusion biopsy. So this talk is somewhat related. Go over some MRI scanner basics and the MRI sequences, and then go over some image review with everybody. And I'll post some multiple choice questions to try to help keep everybody engaged, especially if you're on the West Coast and you're still drinking coffee. My goals for today: you are not going to be a radiologist at the end of this talk. We have fabulous radiology colleagues who spend years in residency and in fellowship to do what I'm going to try to give you a brief summary of in 40 minutes. But it is my hope that you can understand a little bit more about the different MRI sequences and what their strengths and limitations are, and also gain familiarity with being able to look or approach an MRI of the prostate and sort of identify suspicious areas according to sort of the PI-RADS scoring system. Basically, let's demystify prostate MRI. So I love this quote: "Tell me and I forget, teach me and I may remember, involve me and I learn." So pay attention, there are some questions coming at you later. So here's the first one. If you are a resident or fellow on this call, how comfortable do you feel approaching a prostate MRI for suspicious lesion identification? Okay, great. So 46% not comfortable, 36% somewhat. So the vast majority are not or somewhat. And I would say thanks everybody for responding. I would have responded similarly as well. MRI is, I think, one of the hardest imaging modalities for us to interpret it. So very basic prostate anatomy. So you have here a sagittal cross section with the bladder up here and the urethra passing through. The light purple in the periphery is the peripheral zone, and then the transition zone in pink is what sort of surrounds the urethra, and that's where our classic BPH symptoms sort of arise from. And then the central zone, which is posterior to the transition zone and more robust toward the base by the bladder as opposed to the apex down here. So when we look at sort of an axial cross-section of prostate MRI, this is a very simplified drawing of what the different areas of a prostate look like. But I think it's important to understand how everything looks in relation to itself in respect to the MRI image. So here you can see the urethra is right here in the middle with the white oval with the yellowish tan transition zone around it. The bulk around the periphery is the peripheral zone. Anteriorly, and more toward the base and the midgland, we have the anterior fibromuscular stroma, and then posteriorly, we have the central zone. And this is another depiction of it, sort of proceeding from base to mid to apex. So you can see that as you shift from the base to the apex of the prostate, the central zone sort of disappears, and the transition zone also becomes less pronounced, and the peripheral zone here in the apex is more pronounced. So here's an MRI image. So we're going to see a lot more of these, but just to sort of put 1 and 2 side by side, here's your nice peripheral zone, this sort of bright white shape around the periphery of the prostate. I'm sort of making the outline of the prostate right now. And this area here in the sort of middle anterior section is the transition zone. These 2 images here are also other cross sections on axial of the prostate, and this would be a little bit more toward the base because you can see this sort of darker anterior fibromuscular stroma up here. Your urethra is right here. You have a little bit of peripheral zone out here toward the periphery. This corresponds exactly to this picture here, these sort of circular central zones here. Okay. Now, honestly, if there was a virtual prostate exam, don't you think I'd want to be the first to know? So I don't know if anyone's actually laughing when I read that, but I will say that this is relatively appropriate for this talk. You know, we are at a really fascinating time in diagnosing and working up prostate cancer. There are some practices and centers, most notably some of our colleagues who are in London, who really have supplanted prostate cancer screening. The digital rectal exam, they for the most, by and large, don't use it, and it's predominantly MRI up front for anybody with an elevated PSA or strong family history or risk factor. So in this gentleman's case, he would be well served there, although this is not the standard across the board for everybody. So I can't really go into prostate MRI images without briefly mentioning PI-RADS. So you've heard about this before, or if you haven't from one of the talks, I'm sure you've heard the name. So this is essentially a risk assessment tool for reporting the likelihood that clinically significant prostate cancer is present based on the MRI. And this was actually updated last year. So it's now version 2.1. The version 2, which was the preceding version, was updated in 2015. So that stood for 4 years. And it's been developed predominantly by these committees that you see here. It's based on evidence and expert consensus opinion. And you can do an entire talk just on this, so I'm going to spare you those details. But in a very basic sense, the point of this is to interpret the prostate MRI images, the different sequences, and find areas that look suspicious for harboring clinically significant prostate cancer, and giving them a numeric rating based on very specified criteria based on how likely it is that prostate cancer is present. And the ones that we care about, especially for my sake, if I'm going to do an image-guided fusion biopsy, are those lesions with a score of 3 or above. 1 and 2 are benign. So what's the deal with different prostate MRI scanners? There's 1.5 Tesla and 3 Tesla, and you look at 3T, it sounds better than 1.5 Tesla, but really what's the difference? So 3T basically gives twice the signal to noise ratio compared to a 1.5 Tesla scanner. And a signal to noise ratio directly translates to your image quality. So 3 Tesla scanners do provide a better image, better quality image on the prostate MRI pictures that are obtained. Now, that said, not every center has them available or can afford the upgrade if they were traditionally operating on a 1.5 system. So what I will say briefly is that from the literature out there and from the recommendations, the newer 1.5 Tesla scanners can give you adequate images to be able to do PI-RADS interpretation for a radiologist. If it's a much older scanner, it's recommended to use an endorectal coil. It's a fairly, uncomfortable coil that is inserted into the patient's rectum to help immobilize the prostate in the patient to enhance image quality. Another thing to note is that 1.5 Tesla scanners have to be used in some patients that have either hip prostheses that will interfere with the 3T scanners, or if they have 3T incompatible medical devices. Some cardiac devices just cannot work with a 3T scanner. So the PI-RADS committee, as well as our own sort of AUA prostate MRI guidelines, they're on our the AUA website. They do recommend using a 3T scanner if at all possible, if you're trying to evaluate a prostate for staging purposes, for PI-RADS interpretation. However, if not available or incompatible with patient implants or devices, a 1.5 Tesla can be used and it can be interpreted decently. Okay, so moving on now to what the actual different sequences are. I'm trying to break it down into a simplified manner for predominantly the residents, because I know that when I looked at an MRI series of images as a resident, it just looks like a lot of letters and numbers and a ton of images. And for me personally, I found it very overwhelming. And I usually just randomly clicked through them until I could find one that looked like what I was trying to look at. So there are both anatomic sequences and functional sequences. So the number sequences, T1 and T2, are the anatomic sequences. And the functional assessment or the functional sequences are the diffusion weighted imaging with the calculated ADC and the dynamic contrast enhanced. And I'll be going through each of these in a lot of detail now. So for an MRI protocol to actually do a PI-RADS rating or to evaluate a patient prostate for PI-RADS lesions, again, preferably a 3T scanner. Don't necessarily have to use endorectal coil, but you could use a 1.5, and they're going to get all of these sequences performed. The two most important, and you should remember these, are T2 and DWI with ADC. Okay, so T1, remember the numbers are anatomy. T1 is purely to give anatomic detail of the prostate. It is not used for PI-RADS scoring or interpretation. What it can do is it helps to sort of give you the outline of the prostate gland, and it can also help to identify biopsy-related hemorrhage or seminal vesicle hemorrhage. So this is actually a patient of mine. I tried to use my own patient scans when possible, who had an MRI after a biopsy. It was a number of weeks after, but still had some residual hemorrhage here in the left portion of his peripheral zone. So you can see right here, I'm hoping you can see my, my cursor move, otherwise that's going to be a problem. But these really attenuating areas here are purely hemorrhage. So, and you can see the outline of the prostate here, sort of the nice, you know, walnut or whatever kind of nut shape you want to think of. And that's essentially the point of T1. So I'm not going to spend more time on that. Moving on to T2. T2 I'm going to spend more time on because it's one of the most important sequences. If you're going to pull up a prostate MRI, go here first. So T2. A silly thing I always remembered, and I still remember today, T2H2O, T2H2O. That 2 has to do with the brightness of water. So water, T2H2O is bright on a T2 sequence. So it really is it's the other anatomic sequence. It gives you excellent anatomic detail. It really is the best sequence for showing you the different zones in the prostate, the peripheral zone, the central zone, the transition zone. It's also the best sequence to look for surgical planning or for prostate cancer staging. So for example, seminal vesicle invasion, extraprostatic extension, lymph node involvement. This is your sequence to go to for looking for these types of things. Now, these are the two things that I want you to remember, and you're going to hear me say again. Prostate cancer lesions on T2 are dark, okay? And it is the key sequence for finding transition zone tumors. So transition zone tumors are, you know, without going into a lot of detail, a lot more challenging for radiologists to identify compared to peripheral zone tumors. And if I was giving this Grand Rounds talk to my residents, I'd say, how many prostate cancers grow from the transition zone? And somebody would smartly raise their hand and say 20 to 25%. So it's the minority of prostate cancers, but they do occur. And so T2TZ, T2TZ. I'm trying to give you simple things to remember. You're going to use T2 to evaluate for transition zone tumors. And in general, they will look dark. Okay, so try to keep these things in mind. So in general, if you look at when you look at a normal T2 prostate, okay, the peripheral zone is going to have a high signal. It's typically pretty bright, and it's going to look very homogeneous. You saw that on one of my earlier slides. You'll see it again. Now, the transition zone, as a non-radiologist, I will say it looks like a mess. It's a sort of chaotic, disorganized mess because of BPH nodules. It does not have that nice, smooth appearance that the peripheral zone does. And the central zone, which is sometimes harder to identify, especially when it's smaller, has a lower signal. It tends to be darker, not to be misinterpreted for prostate cancer. I will show you examples of these, but just bear this in mind because I said T2TZ. T2 is where you're going to find your transition zone tumors. BPH nodules, okay, when you look at these transition zones and they look like a mess, the BPH nodules are typically very well circumscribed, within their own stroma and capsule. The prostate cancer lesions are typically very poorly circumscribed or lenticular or fusiform. They look more erratic, like a cancer. Okay, so let me just give you these two examples here. These are two men's prostate MRIs with really marked BPH. So if you see out here, these are two T2 scans. This is the peripheral zone kind of squashed down here on the posterior aspect of the prostate. And this whole kind of, you can see this more heterogeneous appearance here is the transition zone. And you can actually see, like, this is a beautiful example right here. Here's a nice, fairly circular, well circumscribed BPH nodule that does not have sort of this erratic appearance of a cancer. And furthermore, I said before, prostate cancers typically look dark. So there's no obvious really dark areas here that that light up. Over here, similar. There is this sort of area over here that looks kind of dark on this left portion of the transition zone, but what I will say to you throughout this as well is you cannot interpret for a prostate cancer with the PI-RADS scoring system on one sequence. You have to put them all together. So this area here did not correspond to suspicion on the other sequences. This is just BPH. Okay, now we're going to look at a couple of suspicious lesions, okay? So again, really robust, kind of nice, smooth, homogeneous, bright-looking peripheral zone. Here's your transition zone up here. And you can see this is normal transition zone. It has good attenuation, but here, this very dark kind of irregular border, irregular shape of the left portion of the transition zone, that is a prostate cancer lesion there. And you have to take my word at it that it matches up on the other sequences as well. Another example here, here's the left portion of the peripheral zone, which is normally sort of this brighter area, but here it is this dark area on the left lateral part of the peripheral zone. So that is also a prostate cancer in the left peripheral zone. This is an even more obvious one. Here we have our nice peripheral zone out here with this really irregular border, dark area on the right lateral portion of the peripheral zone. And you can see here this sort of heterogeneous, messy looking, typical transition zone appearance. Another one, this is one of my patients who had a fusion biopsy. This ended up being a Gleason 3+4, just very irregular, dark area of the right peripheral zone. And again, I mentioned that T2, in addition to anatomy, is really helpful for staging, prostate cancer staging, or surgical planning. So here, you can see that this is actually a prostate cancer extending into periprostatic fat. So in addition to just normal prostate borders anatomy, it also is going to show you staging, extracapsular extension, seminal vesicle invasion, or lymph node positivity. Okay. Now, I do want to just make a quick point here. So there are a couple of other things with T2 images that can sort of throw you or the radiologist off. So there are some non-specific findings, particularly in the peripheral zone, that may confuse you for a prostate cancer lesion. And I showed you one before that did not end up being a cancer. Inflammation, hemorrhage, post-radiation fibrosis, calcifications, even changes after hormone deprivation therapy can all affect the way that the peripheral zone looks, and it could complicate or confound how you are interpreting the image. So you cannot make a call just from one sequence. You have to look at the other ones, which I'll get into to see. So here's a really good example. Here's a gentleman, actually a patient of mine, who has this just very diffusely hypo attenuating appearance throughout his peripheral zone. It doesn't have that sort of bright, normal, homogeneous peripheral zone appearance. And this just ended up being prostatitis. Here's another example. On this gentleman, the left side of the peripheral zone, that's normal. So here's your nice bright white peripheral zone, very homogeneous, smooth, and this very low attenuating, darker appearing right peripheral zone. So if you just looked at this, you could say, well, that might be prostate cancer there. That's clearly not the same as the left. If you look at this with his other sequences, the other sequences did not have the suspicious appearance. And this actually was a acute prostatitis in this portion of his peripheral zone. Okay, so just to remind everybody, T2, prostate cancer tumors look dark. T2TZ, it is the phase or the sequence to look for or for identifying cancers in the transition zone. Okay, now moving on. So now we're going to get into diffusion weighted imaging, or an ADC. So this is the functional assessment of the, or one of the functional sequences of the prostate MRI. And so it's messy looking because it's not a beautiful anatomic picture, and it's just more challenging for us to look at them. So we're going to keep it very simple. This is a functional assessment of diffusion of water molecules in tissue. That's all it's looking at, is how's the water molecules moving. And it's sort of a measure of cellular density. So we all know that in prostate cancer, there's an increase in cellularity, neoplastic growth, and a loss of normal glandular architecture. So because of this, the water molecules cannot move normally. And so there's a lot of restriction of normal diffusion of water. So what that ends up translating to is that on diffusion weighted imaging, there's just water kind of stuck there. It's not really diffusing and moving normally. So there's a high signal, bright signal on diffusion weighted imaging. But the way to account for that or follow up that is the ADC. And what that is an actual calculated measure of the difference of diffusion. So on ADC, prostate cancer has a very low or dark signal, okay? So diffusion weighted imaging, cancers will look very bright. And ADC, there is going to be a very low signal, very dark. And there's actually a lot of studies that have been published that say that the lower the calculated value or coefficient for the ADC value, there's a direct translation to higher Gleason grade of prostate cancer on targeted biopsy in that lesion. Now, DWI ADC, maybe remember this for later. This is the key sequence for looking for peripheral zone tumors, which are the majority of our prostate cancer tumors, okay? Okay, so here are some pictures to look at. These are, like I said, harder to look at. They're messier. They are functional pictures. They are not beautiful anatomic pictures that we like to see as urologists looking at CAT scans, for example. So here we have on the diffusion weighted imaging slice, this really bright area here on the right side of the peripheral zone. And here the calculated diffusion coefficient is very low, very dark. And so it corresponds. You can see that this is bright and this is dark. If this was not a cancer and this was just a tissue that had a lot of diffusion, a lot of water molecules, but it was not a cancer, this calculated value would not look so dark. And that would say to you, that's how you put all the sequences together to say this is not suggesting a cancerous lesion here. Again, challenging to look at, yes, because it's functional, but here you can't quite see the border of the prostate that clearly, or at least I can't, but I can see that this area here on the right side of the peripheral zone is much brighter than the rest of the prostate. And on the calculated ADC sequence, boom, it corresponds to this dark, low attenuating, this dark, low coefficient area in the right lateral peripheral zone. And that is suspicious for a prostate cancer. The rest of this normal peripheral zone here is what the normal ADC, normal tissue, BPH tissue, all has a higher, brighter ADC coefficient. Okay, so before I move on to DCE, just to remind everyone, so DWI, ADC, these are functional sequences, they're not anatomic. And they are the key sequences for looking for peripheral zone prostate cancers. And prostate cancers are going to look very bright on diffusion weighted imaging and dark on ADC. Okay, now the last one that I'm going to go over is DCE, Dynamic Contrast Enhancement Sequence. Again, another functional sequence. So this detects enhancement, but not because of water. It's directly related to vascularity. And so this is the phase that requires contrast administration. So the images are going to be obtained before, during, and after gadolinium. And I'm, not trying to say anything too simple, but again, these are MRIs, so we're talking about gadolinium contrast, not contrast for CAT scans. So prostate cancer lesions. We know cancers are very vascular. They have angiogenic factors. There's a lot more blood vessels. They're going to have a lot more vascularity. They have a high enhancement and they wash out quickly, high blood flow. So you're going to have high DCE expression. It's just purely related to vascularity. And there is some increased enhancement even with a higher cancer grade as well. So it makes sense that prostate cancers are going to light up. They're going to be very bright on DCE sequences. So here we have a nice DCE sequence here, and you can see here in the peripheral zone this really bright area in the right lateral peripheral zone, and this corresponds to a prostate cancer in the right peripheral zone. Now, one thing you have to be mindful of is that there are no sequence is perfect. So similar to T2, there are a number of things on DCE that will mimic prostate cancer, and those will include BPH nodules. You guys have already seen some examples of those sort of bright, heterogeneous appearing, well-circumscribed nodules in the transition zone. Prostatitis, it could be low signal, it could be high signal. It kind of depends on what is happening in the prostate. And hemorrhage, right? Hemorrhage is blood. So hemorrhage is going to look bright here. And I put this on here to remind you, my patient who had that MRI after his biopsy and had hemorrhage in the right peripheral zone, well, there is his DCE image of that. So I'm going to sort of take a quick sidestep here just to make a comment, because this is a little bit of a research interest of mine, and it's also a little bit debated in the literature right now. This whole question of whether to even use the DCE or contrast phase in prostate MRI for detecting prostate cancer. So multiparametric MRI includes contrast. It includes DCE phase. Biparametric MRI does not. So it's the same scan with the exception of eliminating contrast. So you don't give the contrast, the scan is quicker, and you don't have that sequence. There were two very large meta-analyses that were recently reported that compared both the sensitivity and specificity between biparametric and multiparametric MRI. One of these looked at 10 different papers and the other looked at 20. So it was 1,700 and 2,100 plus patients each between the two. And really the overall sensitivity and specificity for clinically significant prostate cancer based on PI-RADS and targeted biopsy was no different between the two. So the authors were suggesting that why use contrast, why use the cost, the invasiveness for the patient. The guidelines or the recommendations are a little bit unclear on this. There are some papers, smaller papers, that strongly support using contrast. The real benefit for using it in a very simplified sense is if you have sort of an intermediate or an indeterminate lesion, a PI-RADS 3, and which you would pick up on the diffusion weighted imaging sequence, and you give contrast and it really lights up, that if it's a transition zone lesion, that will bump it up to a PI-RADS 4. So that's where the real potential difference or benefit of it is. But if you were going to biopsy it anyways, I'm not sure what the real difference is myself, but this is it's a debated topic in literature. So the American College of Radiologists and the society who put together PI-RADS scoring system and have been doing this for years, they recommend that you at least do a multiparametric MRI, so including contrast, when either clinical risk factors indicate the likely presence of significant disease that you really don't want to miss, if they've had a prior negative biparametric MRI and you still are suspicious. So if it was negative but you really think something's going on, give them contrast the next time. Or if they have technical factors that lead to poor or suboptimal image quality of the diffusion weighted imaging phase. Okay, so now we're going to sort of, take it back now to those different sequences, and let's refresh and think, put what we've learned into action here and try to identify a few lesions. So first, we have our T2 anatomic scan here. Aha, oh, I should have given you all a minute. Well, okay, I just sort of gave it away. But you can see here, this T2, again, T2, dark, prostate cancer looks dark, main sequence for looking at transition zone tumors, but of course you can use it to find them anywhere. So we have here a very dark area within the right lateral peripheral zone. This could be prostatitis, this could be cancer. So, okay, let's see what it looks like now on DCE. So it really lights up on DCE, so it's vascular, so that's consistent with a potential cancer. And now let's look at DWI and ADC. So again, DWI, okay, these are our two, all three of these, excuse me, are functional sequences. DWI should be very bright because this is the restricted water movement and it can't really move. The prostate cancer is just trapping it there. So it looks really bright here. And the calculated ADC, again, the darker it is, the more likely it is to be a higher grade cancer, boom. So it met all criteria here, and that then I'm not going to go over the specifics for what PI-RADS number it gets, but that's your suspicious lesion and you are going to target biopsy that area. Again, here's a T2. Let's find our lesion. So we have this sort of normal looking peripheral zone here on the right with this really dark appearing area here. Transition zone here on the right-hand side. So this is normal transition zone here. Again, transition zone is hard to look at, so if these are not so obvious, don't beat yourself up over that, because even the super skilled uroradiologists have a little trouble sometimes with the transition zone. But you can see this heterogeneous appearance with some attenuation on the right side, excuse me, the left side here, which is normal, but it's just all dark on this right side. That is not normal appearing. Here is a what happened to be rated a PI-RADS 5 lesion in the peripheral zone. So again, dark on T2, bright because of vascularity on the DCE or the contrast enhanced phase, bright on diffusion weighted imaging because of the restriction of water movement, and then the calculated diffusion coefficient, dark, okay? Here's a PI-RADS 5 transition zone lesion. So this here may not be quite so obvious. So sort of anteriorly in the transition zone, much more so on the right side here, but maybe spanning over onto the left. I'm not preaching, I'm not claiming to be a radiologist. This, I can tell this looks different from the normal transition zone here, but I would not necessarily just call this as it is. But now let's look at the other sequences. So contrast enhanced, it is definitely lighting up in that same area here. It's clearly very vascular. DWI really taking up, really showing a lot of restriction of diffusion here. So very bright on DWI and dark on ADC. So when you take into account the different scoring criteria, this ended up being rated a 5, predominantly for its size. It's a large tumor. And I think, yeah, this is my last one. So PI-RADS 4, here's another peripheral zone tumor. So this is your last one to kind of pay attention to, and you'll get some questions soon. So left peripheral zone, here's your normal kind of bright peripheral zone, even this, but here's this dark area, dark on T2, that's not normal. Bright on contrast enhancement, same area, bright on diffusion weighted imaging, and dark on the diffusion ADC calculated value. So that also corresponded to a PI-RADS 4 in the left peripheral zone. Okay, so now I'm only putting this in not to really talk about PI-RADS and make a lot of statements about it, but just to remind people that we are human. We are not perfect. Radiologists are not perfect, and MRIs are not perfect. So the PI-RADS version 2, again, remember it was updated to 2.1 last year. They did, this study is quoted a lot. It was a study of 6 experts at different centers, and they looked at their agreement between their scoring of different prostate MRIs based on the PI-RADS V2 system. And what they found was that for the peripheral zone, they had an agreement score of about 0.53 to 0.59. Transition zone was even worse. So it's similar to other radiology studies, but it really shows that you cannot just rely on one person, and we are human. So this is not, these are not always slam dunk findings, and a lot of this really relies on the skill of your radiologist as well as the quality of your MRI. So version 2.1 has recently been looked at, and they found that there was a little bit more agreement now based on the changes that have been implemented for transition zone interpretation. So again, before, transition zone was pretty poor, like 0.38 to 0.5. It went up to about 0.64 in this study. And another recent study also showed improvement in their agreement coefficients for index lesion identification, as well as 85% agreement for determining the absence of lesions, or a negative MRI. So it's certainly an improvement. That's the bottom line, but it is not perfect. And that's the main thing to always keep in mind. There's false positives, there are false negatives. So you as the urologist who are deciding what to do with an MRI read have to know your radiologist, have to know how your MRI scanning is working, and put it in the context of your patient and their story. Okay, so now we're going to just do a few questions because it's sort of the home stretch here. So prostate cancer lesions typically appear dark on which MRI sequence? I love it. Yes, 95% of you got that. Wonderful. That means I'm doing something right here. So yes, dark on T2, bright on DCE, and on diffusion weighted imaging, dark on ADC, which is a calculated value. Okay. Number 2, prostate cancer lesions typically appear bright on which MRI sequences? I might have just told you the answer to that. Wow, that's fantastic. 83% of you got that right. So wonderful. So they are bright on DWI and DCE. DCE is contrast, so it's blood flow. Okay, it picks up the contrast. It's got blood flow going to it. It's vascular. It's bright. Diffusion weighted imaging, it is bright because the water molecules are restricted. They're not diffusing. They're just sort of stuck there. So the two Ds, bright. Think of it that way. That's simple. All right. All right, which MRI sequence is the dominant sequence for identifying prostate cancer in the peripheral zone? Very good. So 62% of you got it right. So diffusion weighted imaging and ADC, that's right. So remember, T2TZ, T2TZ, simple things just to help you remember things. So, so peripheral zone, it is really, this is more of a radiology specific type question, but I still think it's useful to keep in mind. DWI ADC, that is your sequences that are going to really help delineate cancers in the peripheral zone. And which sequence is the dominant sequence for identifying cancer in the transition zone? I hope we get 100% on this one. Okay, 94%, so we're pretty close. So yeah, T2 for the transition zone. So I don't have much else to say about that, but good job. All right. All right, so here's my summary slide, take-home points. Burn these in your memory if you want to try to remember anything from today. Your T2, this is your best sequence for TZ, transition zone lesions, and for prostate anatomy and cancer staging. And your cancers will be dark on this, okay? DWI and ADC, these are your best sequences for peripheral zone cancers or lesions. And your cancers will look bright on DWI and dark on ADC. So they're usually together and they're opposite. Now, dynamic contrast enhanced, that's the DCE phase. It's debated in literature even today about so biparametric versus multiparametric MRI. But if you use it, cancers are going to look bright on DCE. You have to remember, if you're going to look through these, you have to think about all the sequences together. There are false positives and there are things that look like cancer, that mimic cancer, but are not. And you use your other sequences to help you figure that out. And most importantly, work with your radiologists. Know who they are, know how reliable they are. If you're trying to reinterpret or understand how they read something or figure out what to do with a patient, review the scan, the MRI, with your radiologist to get their input into it. And sometimes it may change how they interpreted it. They're not perfect. And there's, I showed you before, there's not 100% agreement between two different radiologists for the same scan ever. So it's a clinical and clinical judgment as well as teamwork. So thank you for this opportunity. Here's my email if anyone has questions or wants to reach out after. And I will also, I have to put this up here as well, and I'll open it up to Rich for questions.
Thank you so much, Kara. That was a great talk, an awesome summation of prostate MRIs for a group of doctors who are probably mostly novices when it comes to reading MRIs. So that was really helpful. We do have a couple of questions. The first one is, can you comment on the use of B-value in assessing the DWI and ADC map?
So I can a little bit. So again, I'm not a radiology expert, but I do know that the higher the B-value, it is a little bit more predictive of what the lesion will end up being on say a targeted biopsy. So, but beyond the specifics of that, I can't give you much more information on the B-value.
Sure. The next one is, can you tell us a little bit about the accuracy of multiparametric MRI in detecting extraprostatic disease, either extracapsular extension or in the lymph nodes, and if that could play any role in surgical planning in terms of nerve sparing or the extent of lymphadenectomy you're planning for?
Yeah, so I don't do radical prostates myself, but I will say that MRI is definitely superior to CAT scans with regards to those exact variables. So cancer staging, being able to detect extra capsular extension or extra prostatic extension, there is some literature suggesting or actually showing that if you use a 3T MRI with an endorectal coil, that you really get your best ability to detect extracapsular extension or extraprostatic extension. That said, I don't think most centers, certainly not us, who are doing 3T scans are using endorectal coils as well. That's my answer.
All right. Do you ever do just targeted biopsies without doing a systematic biopsy at the same time? And if so, does that differ? Do you ever do that on, is it active surveillance patients, cancer naive patients, repeat biopsies, et cetera?
It's a really good question. So it is my my belief, and also from reading the literature on the negative predictive value of a negative MRI, which is not 100%. If you are doing a first-time biopsy on an individual, including fusion, I still do a standard 12-core systematic with that. Now, if they are a surveillance patient and I'm doing a surveillance biopsy, and I know that they only had Gleason 6 to begin with, then I will consider doing just targeted biopsy of their lesions for follow-up. Or if I have a much older patient who got an MRI, has a suspicious lesion, and PSA is really high, and it's really just to prove that there's cancer there, I will sometimes just do a targeted biopsy as well. There are other centers, Caroline Moore and their group, who are mostly just doing targeted biopsy of suspicious lesions, but there is enough literature to say that you will still find some significant cancers, even if there are some Gleason 6s in your standard, that I don't think that you can completely eliminate it on a first-time biopsy.
Sure. Next question, someone wants to know, it seems they've removed the ADC number from PI-RADS 2 scoring. What is your personal opinion on that? And does that change how you interpret it?
Wait, sorry, can you say the question again? So,
that they removed the ADC number from PI-RADS when going from PI-RADS 1 to PI-RADS 2 scorings. What is your personal opinion on that?
I'm not sure if I have an opinion on it. I mean, it's a calculated value, so it's not doing anything extra or different for the patient. I think that it does provide some value. So like I said before, if you have an area on DWI, diffusion weighted imaging, that's bright, but it's not a cancer, it's just bright because it might be inflammation or another reason, it will not have such a low ADC calculated value to correspond to that. So I know that our radiologists, uroradiologists who we work here and who the point people who I trust innately look at those together, but to give you anything more specific than that, I wouldn't be able to comment.
Okay, and do you do your fusion biopsies transrectally or transperineal? And what are your thoughts on each of those modalities?
Great question. So here at Montefiore, we have the Urinav platform, and so all of ours are transrectal right now. I have done a few that are transperineal, mostly in men who've had APRs, so they don't have any transrectal access. But we are working, hopefully, and COVID actually derailed some of our time frame here, to build more of a transperineal platform. I do think that there's a benefit for transperineal, certainly in the ability to avoid antibiotics. Some centers don't use them at all. Some use minimal antibiotics for transperineal, but I do think it is a little bit more of a process with the setup and the positioning and patient comfort compared to transrectal, and so it's It's better for anterior lesions or in a really big prostate. And I think that's where it's the most helpful, and hopefully we'll be able to do that in the future at our institution.
Okay. Based on the sensitivity of MRI in some of the meta-analyses, it seems like MRI still misses about a quarter of clinically significant cancers. How do you approach this, and how do you counsel patients when you're ordering these MRIs for them and talk to them about fusion biopsies?
It's a really good question. And I like whoever wrote that question, because you sort of realistically quoted some of the literature. So MRI is not perfect. That's exactly what I tell patients. It relies on the actual device, so on machines, and it depends on people who are reading and interpreting them, and how well the patient is just laying still for a while during the scan. So if I have a patient, for example, who's referred to me, who has an elevated PSA or a strong family history, and we do a pre-biopsy MRI and it comes back negative, I would not consider that sufficient evidence to completely avoid a biopsy. If, however, I have a patient who, for example, had a negative standard truss 12 standard 12-core template truss biopsy initially, and it was negative, and then his PSA goes up and we get an MRI and that's negative, that negative predictive value is much higher. And so that's a different conversation. I feel more comfortable avoiding a biopsy in that case than in somebody who's never had one that I still have a suspicion may.
Okay, and I think we have time for one more question, probably. So, can you talk a little bit about how you approach PI-RADS 3 lesions on MRI, which obviously can be heterogeneous and a little bit controversial about how you manage those?
Yeah, it's a great question. They're annoying, because there's not always an exact right answer about what to do with them. So if I have, my general approach is this: if it's a patient who has not had a prior biopsy and we've gotten a pre-biopsy MRI and they are there, then given you think about negative predictive value and it's still showing something, even if it's not low likelihood of having clinically significant cancer, I still recommend a fusion biopsy, the standard template, to investigate them. Now, if it's somebody who I know has had a negative biopsy and they have a follow-up MRI because their PSA is going up, and all it shows is PI-RADS 3, then I have a more realistic conversation with them. And say that the likelihood of this having clinically significant prostate cancer is very low, and in fact we've looked at it in our population here in our own hands, because this is also operator dependent and skill dependent, and our positivity rate in our PI-RADS 3s for clinically significant cancer in our demographic is less than 10%. So it's very low, but it's not zero, and so some of it depends on what the patient's comfort level is with taking that chance and not having a repeat biopsy to find out, or if they want to know. So if they're much younger, in their low 50s, I'd be a little bit more aggressive on a repeat biopsy or with a prior negative, and then a PI-RADS 3 to investigate it. If it's an older patient, 70, whatever, for whatever reason we've gotten this or surveilling PI-RADS 3s, then I often will let them be.
And have you noticed, with increasing expertise amongst radiologists regarding prostate MRI and the PI-RADS scoring, a decrease in the number of PI-RADS 3 lesions called on the MRIs?
I have not. At least at our institution. I mean, I can't really speak for other places, but I really have not noticed a big change in that. But what I will say is that we, as an institution, actually stopped using contrast in September of 2020. 19, so 8 months ago. And that came from these meta-analysis systematic reviews that I showed. So our head of prostate MRI radiology is very involved with the committees. And I mean, if it's one of those unique circumstances where it's really warranted to give the contrast to really delineate or be sure, we do that. But by almost routinely, we are not giving contrast, and I'm still seeing a lot of PI-RADS 3s to sift through.
All right, I think it's 1 o'clock, so that's probably all we have time for. But if anyone else has more questions, feel free to email them or reach out to Dr. Watts, and her contact info is on the previous slide.
Thanks, everyone, and be safe. And I really appreciate your attention and time today. This was wonderful.